Dear colleagues, I would like to welcome you to the second Latin American Symposium of Myelodysplastic Syndromes organized by the GLAM group and the second one organized by BM's International Foundation. This event, this biannual event, is very much awaited by all of us as it implies a moment of reunion, fellowship, and regional integration. This year, the symposium will be virtual. We cannot distance ourselves from the reality that we have to live. In this struggle, we have lost friends, colleagues, relatives. For all of those who have departed, our sincere remembrance and our affection for their bereaved. And now, going back to the symposium, it will undoubtedly be characterized by the quality of its speakers, by the great interaction with the public, by the meeting with experts, with patients, and by the production of papers that you have submitted. Everything indicates that we will exceed any expectations. I would like to thank the Uruguayan Society of Hematology for giving us a place in their home, in their place, open their doors, give us support, and allow GLAM to continue growing. To the MDS International Foundation for accepting this challenge and trust in this group. To the hematology societies of the 16 countries that are part of Latin America and this group for sponsoring us. To the Spanish group of Myelodysplastic Syndromes with whom we have agreed collaboration tasks. We also like to thank them. To the pharmaceutical industry, to the laboratories like AbbVie, Novartis, Bristol and Mega Lab, we would like to thank you for sponsoring us. To the associations of patients for lymphomas and leukemias from Colombia and the ACLA group from Argentina. Thank you very much. Your work is represented in the more than 120 patients that are registered in this platform. We would like to open the distance course in its third edition. The distance course in myelodysplastic syndromes is absolutely free for all the members of GLAM. And of course, we would like to invite those of you who are not a member yet to become a member, to take advantage of all these services that we can provide you with. This year, we are going to also inaugurate the Common Latin American Registry of Myelodysplastic Syndromes. We have already been in contact with these Latin American societies in order to have a tool that would allow us to know which are the strengths and the weaknesses of this pathology in our continent. We would like to request you all in this sense that please you fill in a survey that you will find in the platform's lobby, with which we will be able to get to know which are the tools, diagnostic and therapeutical tools in the myelodysplastic syndromes. We are going to be very pleased during these days to provide you to provide a diploma as to recognize as an honorary member Dr. Pierre Fernald. Dr. Jimena Valladares will present the 8th Symposium in Myelodysplastic Syndromes that will be held in Chile. And I also have another announcement. Well, on September 1st to the 3rd of September, we will be together with the Spanish group in Myelodysplastic producing contents of the guides for Myelodysplastic Syndromes, and this will be in the Hematology Congress of Uruguay. This night, we will have also a night of camaraderie with music from Uruguay. You all are invited. It's a show that we want to give to you from the GLAM group. I hope that these symposium will be accompanied by the academic richness that we deserve. May we enjoy it and see you at any time. Now I will give the floor to Dr. Stephen Neimer, who is the chairman of the MDS Foundation. He is director of the Silverstein Compliance Cancer Center. Oscar de la Renta, a professor in cancer research, professor of medicine, biochemistry, and molecular biology from the Miller Medical School from the University of Miami, Florida. Steve, you have the floor.
Much, Marcelo. It's a pleasure to represent the MDS Foundation and to co-sponsor this symposium. The MDS Foundation is celebrating its 27th anniversary. We began having symposium back in 1988 in Austria. And in September this year, we will probably virtually be holding an international symposium in Toronto, Canada. Over the last several years, we've held a regional symposium. The first one was in 2018 in Brazil, in Sao Paulo. This is the second one in Latin America. And we also have had a symposium last year, right at the very beginning of COVID, in Tel Aviv, Israel. I'm pleased to be in Miami. I've been here almost 9 years. The gateway to Latin America is what we call ourselves. We're just about 4,500 miles north of Montevideo. And I'll just say briefly that besides our symposium, every year we have an event at ASH, a Friday, Super Friday breakfast session. We provide a lot of patient support services, caregiver resources. We're a source of referral for clinical trials, and we publish our newsletter. We also have centers of excellence, now roughly 200 centers of excellence around the world representing 40 countries. In addition to the board of directors that Pierre Finot and I represent, we also have a medical and scientific advisory board. We have an international nurse leadership board. And I also want to shout out our executive director, Tracy Iraka, without whom the foundation couldn't exist on a day-to-day basis. We look forward to people interacting. Obviously, I would love to be in Uruguay right now, but virtually to establish collaboration, some new research. And also there's a lot going on in our field, and I look forward to hearing many of the talks to learn what my colleagues are doing. So Marcelo, thank you so much for everything that you've done to make this event happen. And the MDS Foundation is thrilled to be a part of this.
For me, it's a great pleasure that we are all here together sharing. I consider that we are the perfect partners, actually. So now I'll give the floor to session number one, to start session number one, and our moderator, Dr. Gabriela Flores. She is a hematologist from Durand Hospital. Please go ahead. You have the floor and enjoy this day. Good morning. Good morning. Thank you. Thank you very much for the words of Dr. Marcelo E.R. Sterner. I would like to welcome you to the beginning of the first session. I'm Gabriela Flores, and I will be with Dr. Juan Serrano from Venezuela and Colombia, and Dr. Huaman unfortunately had an inconvenient minute ago, so he won't be able to with us. To start the session, we will give the floor to the first speaker, Dr. Elvira Velloso, who will speak about germline predisposition to MDS AML, a clinical point of view. Dr. Velloso is Associate Professor of the University of Sao Paulo and leads the cytogenetic labs of the clinical hospitals and the Israeli Hospital of Sao Paulo in Brazil. Dr. Velloso has participated many times in GLAM. It's a pleasure to have her. Dr. Velloso, you have the floor.
First, I would like to thank the GLAM committee for inviting me to this symposium to talk about a clinical view of germline predisposition to MDS AML. Our first index patient in my hospital was seen in 2010. The patient was a 17-year-old boy with refractory anemia with excess of blasts and monosomy 7 with unilateral lymphedema. His father died at the age of 47 with AML. 1 year after, in 2011, we saw a 21-year male patient referred to us for a persistent thrombocytopenia. He had AML at the age of 10. His younger 19 years old brother had also TAL at the age of 10. There were other two brothers with thrombocytopenia and a sister with a normal blood cell count. What's happened with these patients? They first died of infection during the induction chemotherapy with no diagnosis. We know now that he probably had Emberger syndrome, GATA2 deficiency. The other patient was diagnosed with familial platelet disorder with associated myeloid malignancy, FPD-AML, with RUNX1 mutation. We studied our cohort of adult cytopenic patients diagnosed with MDS and CML, aplastic anemia and Fanconi anemia with clonal evolution, therapy-related myeloid neoplasms, and suspicious of myeloid neoplasms with germline predisposition. From 2010 to 2018, we studied 322 patients. Out of 322 patients, 30 patients, 93% from 25 families were diagnosed with suspicious myeloid neoplasms with germline predisposition. Excluding 6 patients with Fanconi anemia and 7 patients without consented form signed, we finally studied 17 patients from 14 families with this suspicious. Germline predisposition to MDS-AML is not rare even in adults. The incidence of pathogenic germline mutations in children with cancer was estimated to be 8.5% in a large study involving more than 1,000 children. This data has been supported by follow-up studies on different pediatric cohorts. Recent studies on more than 10,000 adults within the Cancer Genomic Atlas dataset reported that approximately 8% of adult patients have a pathogenic germline variant. Many of these patients with germline mutations lack a family history consistent with a predisposition to cancer. The first myeloid neoplasms with germline predisposition was published in 1999 by Song that described the RUNX1 mutation disorder, but these diseases were only recognized in 2016 by WHO classification. 3 classes of disorders were included. The first, myeloid neoplasms with predispositions and pre-existing platelet disorders. These including RUNX1, Ankyrin 26 mutations and ETV6 mutation. Second, myeloid neoplasms with germline predispositions without a pre-existing disorder and organ dysfunctions, including AML with germline CBPA and DDX41 mutations. And third, myeloid neoplasms with germline predispositions and other organ dysfunctions, including GATA2 mutations, myeloid neoplasms associated with classical bone marrow failure syndromes and telomeropathies, Down syndromes, and others. Here we can see that other important germline mutations were diagnosed after 2016. For example, SND9 and SND9L mutations associated with immune deficiency and neurological symptoms in SND9L, and Mirage syndrome in SND9 with MDS, infection, growth restrictions, adrenal hypoplasia, genital alterations, and enteropathy. Also, MECOM mutations associated with thrombocytopenia, radioulnar synostosis, and deafness was described in 2018. Some other mutations, such as HUX1, DDX41, and ATVC, are associated to myeloid and lymphoid malignancies. As the NGS is becoming more used, many other genes are becoming described associated not only to myeloid neoplasms, but also lymphoid and solid tumors. Making The correct diagnosis involves the following first steps. Find out the patient's personal and family history. As you can see in this complex pedigree of one of our patients, sometimes it states 15 to 20 minutes at least. Sometimes the patients and family don't like to recall their tragic health stories. This patient was from a small city in the northeast of Brazil, and the family was viewed as having a devil's disease. Performing a good physical examination looking for subtle findings. Carefully analyze previous laboratory tests, CBC, dysplastic features, platelet size, bone marrow morphology, such as megakaryocytes, types of cytogenetics, and mutations detected in a somatic panel. The last could be also germline. When do you need to suspect germline predisposition to MDS AML? Any patient presented with MDS, acute leukemia with one of the following: thrombocytopenia, bleeding propensity, or macrocytosis preceding the diagnosis of MDS AML by several years, a first or a second degree relative with hematological neoplasm, or a first or second degree relative with a solid tumor consistent with germline predisposition, for example, sarcoma, breast cancer, and brain tumors. Patients with abnormal findings, such as abnormal nails or skin pigmentation, oral leukoplakia, idiopathic pulmonary fibrosis or liver diseases consistent with telomeropathies, lymphedema, atypical infections, immunodeficiency as in GATA2, and congenital limb abnormalities or short stature, as you can see in Fanconi anemia and other disorders. Also, any patients present with MDS with potential germline mutation detecting neoplastic cells, for example, biallelic TBPA, GATA2, RUNX1, or Tp53 mutations. Potential hematopoietic stem cell donor planning to donate it for a family member with hematological malignancy who fails to mobilize stem cells using standard protocols. Okay, then any patient presented with MDS, acute leukemia, with a potential germline detecting neoplastic cells, especially if you have biallelic CBPA, GATA2, RUNX1, or TP53 mutation. Again, a potential hematopoietic stem cell donor who is planning to donate for a family member with hematologic malignancy who fails to mobilize stem cells using standard protocols. And finally, patients with MDS younger than 50, especially if monosomy 7 is presented in the karyotype. In this study from the MD Anderson Cancer Center, the most frequent reason for patients referred to the hereditary hematologic malignancy clinical was diagnosis of hematologic malignancy with a second or first degree relative with hematologic malignancies, potential germline mutations in clonal cells, and diagnosis of hematological malignancy with multiple primary malignancies or family history of cancer. There is a challenge in choosing the test for detections of germline mutations. The comprehensive test must be able to detect single nucleotide mutations and copy number variants in all genes that confer risk. This could be a single gene or a panel or exoma, and sometimes array for CNV detections and even whole genomic study. It's important to remember the most, but not all, germline mutations are coding mutations. The interpretations of the pathogenicity of variants, especially the variants of undetermined significance that lack the experimental documentations of pathogenicity, must be done by the hematologists, geneticists, and the laboratory. The germline tissue in these patients is also something to be discussed because blood, bone marrow, and saliva, the most used samples are contaminated with malignant cells. The best DNA source is obtained from culture fibroblasts obtained from skin biopsy. Hair bulb is an option. However, only low amount of DNA is obtained. The last, but not the least challenging, is cost. Although cost for NGS is decreasing, it is still high for us, especially in South America. There isn't an insurance cover for the patients, and it's more difficult for family members. Sometimes in Brazil, the health insurance asks for an appointment with a geneticist to get the permission to perform the test. Even when no pathogenic mutations is detected, but there is a strong clinical suspicion, the decision must be guided by the patient's personal and family history according to the expert and these Nordic guidelines. The risk for myeloid neoplasm is variable according to the variable penetrance of these many diseases. And the age for myeloid neoplasm diagnosis is also variable. SUNT9, SUNT9L, and NF1 mainly in pediatric age. CATA2, CBPA, and the RUNX1 until 40s, and DDX41 in the over 50 ages group. Progression to MDS-AML occurs through a stepwise process involving loss of the wild-type allele and acquisitions of additional cooperation mutations. Other processes in the middle appear to maintain the wild-type allele, and at the left, SUN9 and SUN9L are unique in that disease progression is observed while when monosomy 7 occurs. SUN9 and SUN9L are genes located at the long arm of chromosome 7. The germline mutations with the genes are associated with gain of function. When patients present with monosomy 7, the clone loses the copy of chromosome 7 with the mutant allele. The haploinsufficiency and other genes located at the chromosome 7 perturbs hematopoiesis and can lead to MDS and AML. Also, cells can acquire the additional mutations for the full disease phenotype. As we discussed previously, there are many diseases. I selected some of them to view in the following slides regarding the hematological and phenotypic findings, the risk of neoplasm, and the somatic mutations. Many of the germline predispositions mutations affect transcription factors important in lineage development, such as HUNX1 or GATA2. The genes encoding these transcription factors also harbor somatic mutations in children and adults with MDS or AML. All of them are autosomal dominant disorders, but can occur as de novo with high but variable penetrance for neoplasms and cancer appear with phenomena anticipations. Starting with germline HUNX1 mutations, FPD, AML malignancy. Okay. Starting with germline RUNX1 mutations, FPD-AML malignancy, more than 200 families have been reported. It's characterized by thrombocytopenia, normal platelet size with decreased platelet function. MDS and AML, but also TAAL are described. The risk for neoplasm is about 40%, with the age of presentation of myeloid neoplasms varying from 6 to 72 years. The patients had also higher incidence of clonal hematopoiesis at a younger age. The germline mutations can be point mutations that produce proteins that act as dominant negatives and have a higher risk to develop AML. Other nonsense frame shift mutations and deletions are also observed. Acquisitions of somatic mutations occurs in the remaining wild-type RUNX1 allele, as well as GATA2 and other genes recurrently mutated in AML and MDS. Returning to our patient with EPD-AML, we learned a lot. We studied the proband bone marrow and peripheral blood. Sanger sequencing study exon 3 to 8 RUNX1 detected no mutations, and our ACGA showed a 163 kb microdeletions in exon 1 to 2 in RUNX1 that was confirmed by MLPA. At the time of the first appointment, we also detect a somatic mutation in PHF6 and the 2.7 deletions at 22q22. The patient refused hematopoietic stem cell transplantations, and after 80 years, he evolved to AML, 19 years after the first AML diagnosis, with normal karyotype, refractory to conventional chemo, and partial response to azacitidine and venetoclax. The patients underwent unrelated hematopoietic stem cell transplantation. He died after a few months from infection. We also studied one brother with no evidence of myeloid neoplasms, and we detected a bone marrow dysplasia with small and hypolobulated megakaryocyte, as you can see here. This data agrees with other research that shows that FPD-AML baseline morphologic bone marrow included dysplastic megakaryopoiesis that is not indicative of MDS evolution. We detect also normal platelet counts in 2 younger patients with the RUNX1 deletion. Therefore, the absence of thrombocytopenia should not be used as an indication for not screening mutations in suspected family and family members. To familial thrombocytopenia syndrome is well recognized, with less risk to evolve to myeloid neoplasms and ALL. In this syndrome, it is important to avoid treatment for ITP and remember increased risk bleeding in invasive procedures. In our cohort with 5 families with familial thrombocytopenia, we detected 2 cases of germline RUNX1 mutations, 1 family with Ankyrin domain 26, 1 family with 30, and 1 family with DiGeorge syndrome. I would like to explain how we performed the genetic test in our cohort. According to the phenotype, we started studying the suspected gene by Sanger sequencing, and then gene deletions was studied by array or MLPA, and finally by whole exome sequencing. Whole exome sequencing was done in the Chicago University and according its pipeline. A myeloid neoplasms and the inherited bone marrow failure panel was used for samples with no mutation detected previously or patients with no familial thrombocytopenia or GATA2 phenotype. Finally, a panel for studying somatic mutations was also applied. Myeloid neoplasms with germline GATA2 mutations or GATA2 haploinsufficiency is described in more than 350 cases. This disease is very heterogeneous in clinical find. Bejar syndrome is with congenital lymphedema, cutaneous warts, and sensorial deafness. Monomac syndrome is with monocytic and mycobacterial infections, cytopenias, and pediatric MDS. Concerning this, GATA2 is present in 7% of all cases, 40% of advanced MDS cases, and up to 72 cases percent of pediatric and adolescents with monosomy 7 MDS. There is also an increased risk for solid tumors associated with HPV infections. Germline mutations are also very heterogeneous, most of them affecting the second zinc finger. Cytogenetic abnormalities are -7, trisomy 8, and trisomy 1q. And AXXL1 is the H2 and HAX mutations were observed. There are some recommendations concerning not using immunosuppression, use immunoglobulin replacement, and we can perform the hematopoietic stem cell transplantations at the early disease of the before clonal disorder appeared. In our cohort of 7 patients, although highly selected by the phenotype, we only found 3 patients with pathogenic GATA2 mutations. In one case, we found an insertion of 27 nucleotides in exon 5, encoding a 9 amino acid in frame insertion that alters the spacing between the 2 GATA2 zinc finger. You have the opportunity to perform functional studies, and the pathogenic variant was confirmed. There are some characteristics in familial AML with mutant DDX41. Myeloid neoplasms occurs at old age, median age of 67 to 70, and clonal disease is more often in men. There are germline frameshift mutations, and somatic alterations include mutations on the second DDX allele and in Tp53. AML with biallelic CBPA has a good prognosis, and we know now that 10% of this leukemia harbor a germline CBPA mutations. These CBPA mutations lead to development of AML with a near completely penetrance, typically in the second or third decade of life, and can occur without a preceding MDS or a cytopenic phase. It has a good prognosis even in the relapses that occur with a different spectrum of acquired mutations. Most of the germline mutations are frameshift or no sense at the 5-line end gene. This results in a protein with a dominant negative activity. Progression to AML is frequently associated with non-acquired mutations in the wild-type CBPA allele. There is no consensus about the necessity of performing the hematopoietic stem cell transplantation for these patients. In our cohort, we didn't have the opportunity to study cases of AML and germline CBPA or DDX41 mutations because no NGS somatic panels were applied for our patients with leukemia at that time, and AML patients were treated in other institutions. Then going to the clinical assessment and management, we know that it must be done for all patients with diagnosed or suspicious of myeloid neoplasms with germline predispositions. As you already discussed, perform detailed personal and family history, physical examination, blood cell counts, and smear revision. For patients with cytopenia and or macrocytosis, perform the aspirated bone marrow biopsy, karyotypic and somatic and study somatic mutations. AGLR typing and consultations and evaluations in a transplant center must be done, especially if cytopenias or evidence of MDS or AML are present at the diagnosis. And the family should be informed about the limitations of follow-up. For example, in cases of evolutions without cytopenias prodromal, and also informed about warning signs and symptoms for evolution to acute leukemia. There is no evidence that the systematic collections of bone marrow material implies the benefit of survivor or early detections of progressions of hematologic neoplasia. However, in these patients, a bone marrow study has been recommended at least once a year or in the worsening of cytopenias. This can lead to earlier performance of hematopoietic stem cell transplantation before progression to acute leukemia and chemo, and associated with better results. In infants and young children, a case-to-case approach based on familial history and the risk of anticipation could be the best. In all cases, treat the infections and be attentive to solid tumors. Concerning hematopoietic stem cell transplantation, choosing the right donor is essential. It's including screening for germline mutations. The indications are severe or symptomatic cytopenias, significant bone marrow dysplasia, increase in thin blast counts, and immunodeficiency in GATA2 or DDX41 mutations. In patients with AML, hypomethylating agents appear to be better than conventional chemo, although a pre-transplant therapy as a bridge to transplant is still required further studies. Genetic counseling is especially important and must be performed by a qualified professional with experience in myeloid neoplasm. How to predict the risk for neoplasm? It's difficult because the degree of varied penetrance of some syndromes and the phenomenon of anticipations make it difficult. And in children, counseling should be done consistently, and it is recommended that the children agree to genetic testing as long as they are of age and understanding. We have many challenges to improve molecular detections of germline mutations with mechanistic studies and clinical interpretations, to increase the suspicion index of clinical hematologists and transplant centers, to develop strategies to make diagnosis available in clinical practices. Does it need to be a standard practice for all myeloid neoplasms candidate to hematopoietic stem cell transplantations? The establishment of centers of excellence with multidisciplinary teams to give patients and family members support and international collaboration. I would like to thank all the team that work on this study in Hospital das Clínicas da Faculdade de Medicina da USP, in the laboratories at Universidade de São Paulo, and especially to Marcela, the postgraduate student, and Dr. Lucy Godley from the University of Chicago that assisted in Nexome's studies. And I'll be happy to take questions.
Well, thank you very much to Dr. Elvira for that wonderful presentation, very explicit. Now I will introduce Dr. Rafael Behar, MD, PhD, which is a specialist certified in internal medicine, medical oncology, and hematology. Dr. Behar completed his internal medicine residence in Birmingham and Huaman Hospital in Boston. He was later a chief of medical resident. Then received his fellowship training in hematology and oncology at the Dana-Farber Cancer Center Institute. He earned his medical degree of PhD at the UC of San Diego School of Medicine. He's also an associate professor of medicine at the institution. Dr. Behar has a special interest in hematology malignancies. We focus on the care of patients with Myelodysplastic syndromes and related blood disorders. Dr. Behar established MDS Center of Excellence in the UC San Diego Health Center, the Moore Cancer Center in La Jolla, California, which provide diagnostic tools, supportive care, clinical trials, and medical expertise. In addition to caring of patients, he runs a research lab dedicated to study of MDS. He has published a number of key papers in the New England Journal of Medicine and Journal of Clinical Oncology, describing the genetic changes in drive involvement of MDS. He therefore led to important research in the field of mutation that help predict prognosis and life treatment options for MDS. Dr. Behar.
Dr. Serrano, thank you for the introduction. Gracias por la introducción. Yo encantado de estar aquí con ustedes. Una pena que no lo podemos hacer en Montevideo. Capaz que pronto se podrá hacer de nuevo de esa manera. Si me perdonan, voy a dar la charla en inglés, que me viene un poquito más fácil, y así no nos quedamos a tiempo. So switching gears, I'll be speaking about genetic mutations in myelodysplastic syndromes and how far we've come over the last 10 or 15 years incorporating these lesions into our care of patients. So I'll go over markers of diagnosis and disease subtypes that can be influenced by somatic mutations, how we can use somatic mutations to refine the risk stratification beyond what we can do with the IPSS and the IPSSR. And then I'll point out that there are several drugs that can be selected based in part on molecular features like mutations and other things. And finally, we'll talk about how we can use these for looking at immunologic targets and even in the special case of patients with Tp53 mutations. So we'll start by looking at somatic mutations as diagnostic markers and use for disease classification. So thinking back to 2018, the last time that I was in Montevideo giving a talk about MDS, we had already understood the genetic landscape of MDS, I think, fairly reasonably well. We knew what the most frequently mutated genes were, largely genes involved in splicing, epigenetic regulation, and myeloid transcription factors. And I would say that since then, now in 2021, we haven't necessarily added a lot to this understanding, but there may be a few genes that have been added that I think are important to discuss, including DDX41, casein kinase 1A1, and a few others. But in general, the landscape is very similar than it was then. I think what's changed is that we have now a better understanding about the implications of some of these mutations, how best to incorporate them into our practice. And we are, I think, again, one step closer to having expert guidelines that will help us utilize these mutations in, I think, in a more fruitful way. So I'll start by reminding you about the MDS classification according to the World Health Organization, that this is largely based on morphologic features and other clinical findings. However, there are two subtypes that have some genetic component to them. One is the longstanding MDS with isolated del5q that has been with us for quite some time. And the other is MDS with ring sideroblasts, particularly when the ring sideroblasts are less than 15%. Some of these patients can be classified as MDS if they carry a mutation in SF3B1. I think it's important that these genetic subgroups be recognized not just because they share clinical features, but because they also may share some propensity to respond to certain agents that we might use to treat these individuals. What about those people with cytopenias who don't quite meet the diagnosis of MDS? We did a study a while back looking at patients who were suspected of having MDS, underwent a bone marrow biopsy, and then had that biopsy material sequenced for mutations. Now, some of them did have MDS after all, and when we sequenced those samples, a very large proportion, 96%, carried one or more somatic mutations or chromosomal abnormalities. But it was interesting that those individuals who did not meet the diagnostic criteria for MDS, but did have some degree of dysplasia, more than 70% of them did have a mutation or chromosomal abnormality. And even in some of those individuals that had no evidence of MDS on their bone marrow biopsy, the rates of clonal hematopoiesis were quite high. They were 27%, much more than you would expect in the background. Now, previously, we would have called those individuals that did not meet the diagnostic criteria for MDS as having an idiopathic cytopenia of undetermined significance. But now we could identify a subset, about 35%, that had a clonal cytopenia of undetermined significance. And the question was, what happens to these patients going forward? Do we need to pay special attention to them? Or might they even behave like patients with MDS? Dr. Luca Malcavati and his group helped address this question. They examined about 140 patients, again, suspected of having a myeloid malignancy, who did not meet diagnostic criteria for any disease. They sequenced these samples and found that in the absence of mutations, the likelihood of progression to a myeloid disorder was quite low. However, if there was one mutation, the risk went up to about 45 or 50%. Two mutations, it was closer to 60%. And for three or more mutations, that risk was almost 80%. And if you look at it by the type of mutation, certain mutations were more predictive. So mutations in splicing factors, RUNX1, JAK2, or patients with multiple mutations had a very high likelihood of progression to a frank myeloid malignancy like largely MDS, approaching 100% at 5 years. Patients who had single mutations of DNMT3A, TET2, or ASXL1 had a lower risk, but still pretty substantial. This is about 50% at 4 years. But importantly, those patients who had no mutations identified on a broad gene panel had a very low risk of progressive disease. So this is one way that we can use mutations today to help us understand the risk of patients who may not yet meet the diagnostic criteria for MDS, but might be considered as having either pre-MDS or having an indolent MDS syndrome that has less dysplasia. So in working with the International Working Group to help develop a molecularly integrated prognostic scoring system, we realized that it was very hard to separate prognosis from classification, that there were certain fairly obvious groups of patients that had shared molecular features, and within those groups, the relative risk of mutations was different than it might be in other groups that had other genetic profiles. So the first question that we needed to ask was whether there were genetic subtypes of MDS that should be considered separately. And I'll give you some examples of what those might look like based on our knowledge today. We already know that patients with del(5q), for example, represent their own group, but perhaps patients with SF3B1 mutations should also represent a separate group, and patients with Tp53 mutations might represent a separate group. And those patients that have shown the capacity to generate excess blasts above 5% in their bone marrow, perhaps those patients are another group. In each of these individual groups will have differences in prognosis, but importantly, the mutations that occur in these groups may also have differences in their risk associated with them. So perhaps the first thing we need to do is reclassify MDS in a genetic manner before we start actually examining mutations more closely. I'll give you an example. So patients that have an SF3B1 mutation in MDS generally have a better prognosis than patients with other types of mutations. If we look at the co-mutated genes in this patient population, we see that SF3B1 mutant patients have very few mutations in other genes except for Tp2 and DNMT3A. They don't carry many of the adverse mutations like ASXL1, splicing factor mutations, Tp53, and RUNX1 that patients who do not have an SF3B1 mutation often carry. So perhaps the favorable prognosis of SF3B1 mutant MDS is not necessarily due to that mutation, but due to the fact that they don't have many other adverse mutations as defined by their genetic profile. Now, a similar story can be developed for patients who have complex karyotype MDS. Complex karyotype MDS has a very high frequency of Tp53 mutation, more than 50%. And these patients also have very few co-mutated genes. They do have 3 or more chromosomal abnormalities much of the time, but their mutation profile is again quite different, suggesting that they might represent their own independent genetic group of MDS. And again, we have to weigh the influence of mutations differently in this group than we might in the SF3B1 mutant group. So it might be better to break them out. So after we've done that and suggested that there might be subgroups, we need to consider expanding the definition of MDS perhaps to include some of those patients with CCUS, the clonal cytopenias of undetermined significance. And then importantly, understand which patients with MDS might actually have an early form of acute leukemia. So there may be some mutations in MDS that predispose to AML and with a high likelihood. And perhaps those patients should be recognized as well. I'll show you some examples. For patients with myeloproliferative neoplasms, a similar approach has been utilized and published. Here, it didn't matter whether patients were diagnosed with essential thrombocythemia, polycythemia vera, or myelofibrosis. Sequencing was performed on patients with these myeloproliferative neoplasms, and then groups that were similar based on genetic features were identified. And then the highest priority groups were pulled out first. So in this example, patients with Tp53 mutations, regardless of their diagnosis clinically, were identified as having a very poor prognosis, and they formed their own group. After those patients were removed, patients with chromatin or spliceosome mutations were identified, and those patients represented their own group. So something similar is likely to be the case with MDS in the future when we have a better molecular understanding of the different subtypes of MDS that might occur. And I'll point out that something similar has been done with acute myeloid leukemia, where a genetic analysis has identified distinct subgroups, many of which are shared with myeloproliferative neoplasms and myelodysplastic syndromes, including that important group characterized by mutations in Tp53. And we've gone back and looked at data collected in centers around the world where people have done sequencing of their MDS patients. We've compiled that data and looked to see if there are any obvious patterns that jumped out at us. Importantly, we saw this evidence of SF3B1 mutations as being favorable, where those patients had a longer overall survival than did patients without any mutations. And then we saw a very obvious pattern that for each additional mutation that patients had that were not SF3B1, shown here in red, the prognosis got progressively worse. So we can say that the number of mutations is a strong has a strong association with the overall prognosis. Now, we need to take a closer look at this because this isn't enough, I think, to characterize our patients. Certain mutations are more important than others, for example. So in particular, we focused on patients who had less than 5% blasts, patients that we typically think of as having a favorable prognosis or an indolent course of disease. We asked if any mutations were associated with worse outcomes than the IPSSR would predict. And we found that there were a large number, and those are shown in the upper right-hand quadrant of this graph, those patients that have a higher hazard ratio after adjustment for the IPSSR risk group. Only one gene was considered favorable, or more favorable than the IPSSR would predict, and that was SF3B1 shown on the left. To give you a sense of what the impact of these mutations are on our prognosis, I'll show you what happens when you look for patients that have mutations in this circle. First, the survival of patients with SF3B1 mutations is a little bit better than those that have none of these 10 mutations. But if patients have one or more mutations in that upper right-hand quadrant, ASXL1, RUNX1, TP53, and so on, their survival is substantially shorter. It's about 1/3 of what it is for patients that have no mutations. So this is important to understand that mutations can help us refine our prognostic interpretation of patients with MDS and identify those patients that are likely to do worse than we might have predicted. And perhaps these patients should be treated sooner or referred for transplant sooner or watched more closely, as they have a higher likelihood of dying from their disease in a short amount of time. Now, there is some nuance to this, and this is one of the reasons that we've taken our time to develop a panel that is both accurate, interpretable, and easy to use. So one example here is that if a patient has 2 adverse mutations, for example, is their prognosis actually worse? And the answer is that it depends on the mutations. If ASXL1 and SRSF2 are mutated, the patient does indeed have an inferior outcome. However, if a patient has an SF3B1 mutation and a DNMT3A mutation, for example, their outcome is no different than if they have an SF3B1 mutation alone. However, when we encounter a DNMT3 mutation by itself, often that outcome is a little bit worse. So the answer here is that the clinical and the genetic context both matter. That we need to understand not just whether a patient has a particular mutation, but we need to understand all of the mutations that a patient has to accurately interpret the impact of those mutations. And as the International Working Group comes up with an integrated model, you'll see that these factors are taken into account. I'll give you one example of what the IWG has already found and been able to publish. And this has to do, again, with TP53 mutations. Some patients will have only one allele of TP53 mutated. Others will have one allele mutated and the other allele either mutated or deleted or duplicated in a way that no wild type allele remains. And there are differences in outcomes based on this TP53 mutation configuration. In particular, those patients who only have one TP53 mutation and retain a wild type copy, their outcome is not as bad as we might have feared. Their outcome, in fact, looks a lot like that of patients who do not have any TP53 mutations. But when both alleles of TP53 are affected, the outcomes are even worse than we thought. They're one of the most significant adverse findings that we can have in MDS. And unfortunately, it's not enough to simply sequence a patient and measure the abundance of TP53 to know whether a wild type allele remains. There are some patients with a single mutation who have that in a very dominant clone, and those patients may not have as bad of an outcome as those individuals who have 2 alleles affected. And several of those individuals who have 2 alleles affected have a very small clone, meaning that clone may look like it's not very abundant, but it has this negative potential that we need to be aware of. So I think in the future, sequencing studies will need to take into account not only whether or not mutations are present, but in what form are they present? Are they formed as hemizygous alleles, heterozygous alleles, or homozygous alleles? So I'll switch gears now and talk about molecular determinants of response and resistance. Again, as I mentioned, there were 2 genetically defined subtypes of MDS, and importantly, these can infect your choice of therapy. I'll start with lenalidomide. I think this is our classic example of a drug that is genetically selected. For patients who have del(5q), lenalidomide will act on casein kinase 1A1, a haploinsufficient gene in these individuals, and can lead to very meaningful response rates that are very profound and very durable. And likely this drug improves overall survival. But again, it has to be in the right patient. Patients that have this del5q abnormality, the drug is less effective in those individuals who do not have a del5q. That said, mutations can also help us understand the likelihood of patients relapsing or being resistant to lenalidomide. In this study that examined many lenalidomide-treated patients, they identified that those that progressed after treatment to acute leukemia, for example, often had mutations of Tp53 either at the outset or at the time of progression, or had mutations in RUNX1. So while I would not use mutations in these genes to exclude patients from therapy, it might set my expectations that these patients are more likely to relapse. Now, switching gears to another lower risk patient population, those patients with SF3B1 mutations that might be transfusion dependent, we have a new drug in the United States called luspatercept that has been approved to treat the anemia in these individuals. And in their phase 3 study, low risk MDS patients with ring sideroblasts were treated with luspatercept if they were either refractory or unlikely to respond to growth factors. And what they found was a meaningful response rate and a meaningful period of transfusion independence in this patient population. And patients with ring sideroblasts were singled out because in earlier studies, they seem to have the best response rates. They seem to be the ones who are benefiting the most. There is a current study now examining all comers, patients with ring sideroblasts and without, to see if there is this selectivity there. But at least for now, we believe that patients with ring sideroblasts are more likely to benefit from this therapy. I do want to mention patients who have IDH mutations, IDH1 or IDH2. These mutations are very unique. They don't incapacitate their target, they actually alter its function and cause it to produce a new metabolite that then interferes with other cellular processes, including the activity of genes like TET2. Now, we have inhibitors against these mutations, but unfortunately, mutations of IDH1 and IDH2 are relatively rare in MDS, occurring only in about 5% of patients. But these inhibitors, enasidenib and ivosidenib, are available to us in the United States as they have approvals in other indications. And they do show activity as single agents and are being studied now in combination as well, and may become an option for our patients going forward, even though there aren't many of them that necessarily carry these mutations. As I'll show you in a little bit, mutations of IDH can be predictors of eventual development of AML, and we may have good reason to treat them early if we find them. And lastly, another drug that is also relatively new to our armamentarium in MDS is Venetoclax. And Venetoclax in combination with hypomethylating agents has been very effective in patients with acute myeloid leukemia. However, we already start to see patterns of resistance that can occur based on their mutational profiles. Patients with typical de novo AML mutations like NPM1 and IDH2 tend to be very sensitive to treatment. However, patients who have mutations in FLT3 or RAS pathway genes tend to be relatively resistant or relapse early. And as you can see in the red line here, patients that have FLT3 ITD mutations will often see that clone grow and expand as patients become resistant to this disease and makes them more likely to be resistant. So this suggests that perhaps we should be combining Venetoclax with drugs that can target these other lesions if these mutations are present. Now I want to focus on mutations and how they might be able to help us understand which patients are likely to respond to hypomethylating agents. We performed a study a while back that examined over 200 patients treated with hypomethylating agents. And we asked if any mutations were associated with response. Now, there wasn't a very strong signal here. Mutations at baseline weren't necessarily very tightly correlated with response. However, if we excluded those mutations that were present in very low abundance, we did see a signal for TET2 mutations having an increased likelihood of responding to this drug, particularly in patients who did not have an ASXL1 mutation. So this last subgroup had a greater than threefold increase in their likelihood of response. Again, not enough, I think, to exclude patients who don't have this mutational profile from treatment since we don't have many other options, but a way to set expectations. And recently, our findings were validated in an independent cohort of over 240 patients treated primarily with azacitidine, where a very similar pattern was observed. That is, that patients with TET2 mutations and no ASXL1 mutation were the ones that were most likely to respond, whereas patients with ASXL1 mutations alone had the lowest response rate. So if mutations are not excellent predictors of response, are there other ways that we might predict response to hypomethylating agents? We do know that if you treat patients with MDS for several cycles and they do respond, that their DNA methylation is lower. Whereas if they have stable disease or if they have progressive disease, their DNA methylation in fact tends to go up despite the treatment with a hypomethylating agent. So perhaps we're not looking at the right marker, or even not even looking at the right time. Our group and several others have looked for methylation signatures at baseline that might predict response, and largely have not found very robust markers. So we've taken a different approach where we're asking whether epigenetic or DNA methylation profiles that occur after a patient has started therapy might be more predictive of an eventual response. This has the advantage that it takes into account some patient-specific features that we can't ask about at baseline, namely how they actually metabolize the drug, what kind of exposure they see, and what is their propensity to remethylate cells that have already been exposed to drugs like azacitidine. So to do this, we had the good fortune of being able to work with Takeda on their Venetoclax 2001 study. This is a study of patients who received azacitidine with or without an experimental agent called pevonedistat. Samples were collected at baseline prior to treatment, and again after 2 cycles of therapy. We had some samples that were paired. We had both the first and second sample, and we could look for DNA methylation signatures that were associated with eventual response. Most patients had not responded by cycle 2. What we found is that those patients with the greatest degree of demethylation in their bone marrow samples were the ones that were more likely to have a response, particularly a complete response, where they also saw improvement in their blood counts. Patients who had very little demethylation, on the other hand, by cycle 2, were more likely to not respond or have a less than complete response. This is shown in this time to response curve that it shows if you take patients treated with azacitidine and look at those that have the greatest degree of demethylation, in this case just more than the median, they have a higher likelihood of response and a more rapid time to response than patients who have less than the median amount of demethylation, who are less likely to respond, and if they do so later. We also looked at the entire epigenetic profile, not just the demethylated samples, to see if there were any clusters that occurred. At baseline, the pretreatment sample, we didn't identify anything obvious. However, we did find tighter clusters present in the second bone marrow sample at cycle 2, day 22, that suggested a convergence after treatment. And in particular, there was one group in the upper right-hand corner here shown in blue that was enriched for responding patients. In fact, all patients in this group had a response to therapy. And when we took a look at the methylated sites in the DNA that were responsible for membership in this group, this cluster B shown here, the mass majority of these sites, more than 4,000 sites, were demethylated. Whereas for the other groups, the methylation sites that were associated with inclusion tended to be hypermethylated. So we're now examining what these hypomethylated sites are and what they can tell us about the biology of disease, and perhaps allow us to use this cycle 2 time point as a way to predict eventual response in this patient population. All right, so now I'll switch gears to talk about therapies active against Tp53 mutations. I think importantly, this paper published in 2017 by one of my medical school colleagues, Dr. John Welch, examined patients with MDS and AML treated with high doses of decitabine, a 10-day course. And they had a very high response rate for this Tp53 mutant population that wasn't just improvement in counts, it was also significant reduction in the mutant allele burden. So the amount of Tp53 mutant disease shrunk substantially after 4 cycles of treatment. And since these patients have such poor outcomes after transplant, in fact shown here in 2 separate studies that transplant success rates are less than half in the Tp53 mutant population, largely due to relapse disease, perhaps by shrinking the amount of Tp53 that patients have prior to transplant, we might be able to delay relapse, allow engraftment, and achieve a better long-term outcome. So this is being studied now in the clinical trials. However, we also have drugs that directly target the mutant P53. This is a drug called APR-246, or Aprentapopt, that in phase 2 studies had a really remarkable response rate of over 80% in patients with MDS and AML. Now, unfortunately, in the phase 3 clinical trial, the complete response rate wasn't the 50% that we saw in phase 2, it was closer to 33%. So this was considered a negative study, but I think it's still fairly impressive that this patient population with such an adverse marker had an improved rate of complete response. And now we're waiting to see how durable these responses are. And hopefully this drug will move forward, as I think it's an important agent for patients in with this type of disease. Another recently studied drug that has activity against TP53 mutant MDS is called magrolimab. This is an antibody that binds CD47. And CD47 is a protein that is expressed on the surface of cells that tells macrophages to leave them alone. We call it the don't eat me signal. So tumors that often have abnormal cell surface proteins that attract the attention of macrophages will express CD47 on their surface in order to avoid being consumed by them. And this drug blocks that signal and allows macrophages to recognize the tumors and eliminate them. And in clinical studies of MDS and AML, the response rates were, again, fairly remarkable. 90% response rates in MDS with a 42% complete response rate, very significant reduction in bone marrow blasts, as shown on the waterfall plot on the right. And importantly, those patients that had TP53 mutant MDS had a similar response rate and also showed clearance of that AB mutant clone. That clone went down to undetectable levels after a few cycles of therapy, suggesting again that this might be a strategy that allows us to reduce the burden of disease in these patients and take them to transplant, where transplant might then be more successful. And the last slide I want to leave you with is a study that we participated in where we can actually use mutations not just as markers of disease, but as targets of disease. And in this case, employing the immune system. What we do is sequence a patient's MDS, identify those somatic mutations that change the protein coding sequence and are likely to be expressed. We synthesize those mutant proteins and expose the patient's own T cells to these mutant proteins in the lab. Those T cells that recognize the mutated protein are then grown and expanded and infused back into the patient in what we call an adoptive neoantigen-specific T cell therapy. We've treated 3 patients with this successfully, showing that this is both feasible and safe, and now are hoping to move forward in a way that allows us to see more meaningful responses at higher doses with conditioning therapy. So I'll summarize that mutations are immensely important in MDS. I think that it is now the standard of care at most centers in the United States to sequence patients because they can help us diagnose and classify them. They can help us refine the prognosis, help us select when and how to treat, and also to predict which patients are likely to have resistance or relapse to treatment. We may go beyond mutations to look at epigenetic factors for HMA therapies, and ideally, we need more therapies that target the mutational profile of patients with MDS. So with that, I'll end and join you at the final panel for questions. Thank you.
Bueno, doctor Bejar, muchísimas gracias por esta excelente presentación.
This excellent presentation. Now we will leave questions until the end. Now we will present the third speaker who will speak about the role of cytogenetics in the molecular area, Dr. Belli. Dr. Carolina Belli is a doctor of genetics from the UBA. She has special interest in the cytogenetic study. She's deputy founder of CONICET. She works at the hematological lab at the Institute of Experimental Science. It is actually a pleasure to receive her. Dr. Carolina, the floor is yours now.
I would like to thank to the MDS Foundation for supporting our GLAM meeting, this opportunity. So, and since my Spanish is better than my English, I prefer to continue my talk in Spanish. ¿Cuáles son las herramientas que nosotros contamos?
Tools that we have at the cytogenetic lab to collaborate in the correct diagnosis, classification, and prognosis of myelodysplastic syndrome patients. The karyotype, by way of conventional techniques, the use of fluorescent probes for the FISH procedure, the possibility of using arrays of CTH or CNP, the sequencing by way of subclub techniques, or the use of new generation sequencing, and the immunohistochemistry techniques to evaluate the overexpression of, for instance, the P53 protein. However, from all of these studies, apart from the morphological evaluation and the blast count in the bone marrow, the only mandatory study is still the establishment of the karyotype by way of conventional techniques. So this cytogenetic analysis is important for the establishment of the pathogenesis diagnosis, though there are no pathognomonic alterations and none is specific of any morphological subtype. It works for the prognosis because this has been incorporated in all the risk prevention systems and in the selection of the therapies adapted to the risk and the evaluation of the subsequent response to the treatment. What we can observe here is that the cytogenetic findings correspond to a wide array of possibilities, and around 50–60% of patients present normal karyotypes. These findings were corroborated in a collaboration between the Argentinian group and the Brazilian group, where we actually proved that the cytogenetic alterations are observed in patients with de novo characteristics from 40 to 50%, while in the secondary patients, there's an increased percentage towards 70–90%, with an increase in the presence of high-risk karyotypes, especially in the presence of complex karyotypes with more than 3 cytogenetic alterations. What are the chromosomes which are involved in these patients or alterations? Is the 5, 7, 8, 11, and 20. And what we can see here, excluding chromosome 11, is that 65% of the altered karyotypes affect the 5, 7, 8, and 20 chromosomes. What are the alterations that are more frequently found in these patients, known by all of us, is the deletion of the long arm of the 5q, the long arm of 7 chromosome, the long arm of the 20 chromosome, the loss of the 7, the trisomy of 8, trisomy of 21, and the Y loss. And if we observe the color inside the bars, we see that there's a prevalence of red and orange, which implies that there's a predominance of partial losses or total losses in the indicated chromosomes. Particularly if we take into consideration the myelodysplastic syndrome associated to the deletion of 5q, we can see through G banding techniques that this might affect different portions of the long arm of chromosome 5. We can also apply FISH techniques by way of the use of locus-specific probes, and thanks to the recognition of the region by applying array techniques, we were able to recognize not only important genes in the pathogenesis of these syndromes, but also we located the probes in those regions by decreasing the possibility of false negatives in the diagnosis of these patients. Stemming from 2016, or starting in 2016, these patients could also present some other alteration, cytogenetic alteration, accompanying the 5q deletion, like here, with a balanced translocation between the chromosomes 2 and 11, which is evidenced by the complete painting of chromosome 11. The lack of response, like in a new treatment, considering lenalidomide is associated with a short survival and also to a greater risk of evolution towards AML. So therefore, follow-up of patients by way of cytogenetic techniques is also something that collaborates in the evaluation of their response to treatment. Now, if we use or only use the locus-specific probes for watching what is the deletion of the long arm of chromosome 5, we can have some alterations that go unnoticed, especially within the context of complex karyotypes. These complex karyotypes will also predict a poor response to, for instance, lenalidomide. The presence of cytogenetic alterations, which are recurrent, like those in the list presented by the WHO in its different versions, might be considered as presumptive of a myelodysplastic syndrome within the context of persistent cytopenias and absence of the characteristic neoplastic findings. Part of the list, we can see most of the before mentioned alterations and a small group of balanced translocations, most of which are observed in patients with secondary characteristics. As part of this list, there are the losses of the Y chromosome, because we can see this in the elderly, though some authors consider that their observation in more than 75% in the metaphases analyzed might be considered as something that suggests the neoplastic clone. The deletion of the long arm of the chromosome 20 can be seen in our clinical presentations, and the presence of trisomy 8 can also be observed in a connotation of constitutional characteristics. With the recognition of the independent prognostic value of the cytogenetic findings in 1993, all of the prediction systems have incorporated the cytogenetic findings within their risk classification, particularly with a consensus established in 1997 by the collaboration group of myelodysplastic syndromes. The prognostic independent value was recognized of most of the cytogenetic alterations, which have already been mentioned, establishing 3 risk groups, which are highly reproducible in the literature and in our personal experience in South America. Now, based on the preliminary findings of Jans and collaborators in 2012, recognition of some alterations found less frequently was indicated, and there are 5 risk groups which make the foundation of the revised risk system in 2012. This classification allowed us, for instance, to elucidate that the presence of the long arm of chromosome 7 had a different prognosis from the loss of the 7, establishing thus an intermediate risk and the other adverse risk profile. This risk classification has been reproduced in different series, including the experience with the collaboration between Argentina and Brazil. Something that we could also see as well is that the presence of high-risk karyotypes favors a short survival or poor survival. It's associated to a poor survival either with or without AML evolution. This suggests that the presence of high-risk karyotypes favors medullary failure in patients with MDS. Another important consideration to bear in mind is the response to the drugs or hypomethylating agents. What we can see here is that the presence of high-risk karyotypes poses an independent prognostic value, independent from the platelet count less than 30,000 and hemoglobin lower than 10, being a male or an elderly, with regards to the poor survival of those patients who are treated with hypomethylating agents. As we already introduced, the patients with MDS are characterized by deletions and partial deletions or monosomies, which affect 67% of the altered karyotypes. Within this context, it is important, or was important, to evaluate the implications of the monosomal karyotypes in patients with MDS, something that's observed both in the Argentinian series and the Spanish series. This is that the prognosis of patients with monosomal karyotypes is not statistically different in the presence of complex karyotypes regarding their poor prognosis. Recently, the international working group managed to collect information of around 6,500 patients and was able to compare the presence or the characteristic of the cytogenetic findings in both subtypes. Something that can be seen here is that the patients with secondary characteristics are characterized by a lower frequency of normal karyotypes, and those altered karyotypes are characterized by a greater frequency in complex karyotypes and a greater frequency of those complex karyotypes with equal to more than 5 cytogenetic alterations. Something that the international group proved is that the distribution of risk groups in patients with secondary characteristics coincide with a differential prognosis both in terms of survival and of evolution towards AML. Another important point that has gained certain relevance in the past years has to do with the hits, which affect the tumor suppressing gene Tp53. The tumor suppressor P53 is the garden of the genome. And according to the Knudsen hypothesis that goes back 50 years, there should remain a residual wild-type allele to keep the genomic stability of the cell. Now, what are those cytogenetic hits which might we recognize regarding TP53? These are those hits which affect chromosome 17. It's a short arm mainly. Those hits might include deletions of the short arm, total loss of the 17 chromosome, and some other structural alterations which might affect the short arm. We can see them with FISH techniques with a locus-specific probe that will map the P53 locus. We can see the cytogenetic array with the presence of the long arm of chromosome 17, complex alterations like the one that corresponds to a dicentric chromosome between 5 and the short arm of chromosome 17. Or else we can see the almost full loss of the short arm of chromosome 17. What I usually advise here is that in view of this type of structural complex alterations, which are not that frequent, you can resort to the cytogenetic atlas which usually have examples and different characteristics that might help us understand how complex these findings are. Hernar and colaboradores and collaborators last year compiled the information of 3,324 patients. 12% of them had a hit which affected the TP53, two-thirds of which had multi-hits, meaning that they had more than one event which could affect the P53 locus. This multi-hit presence is associated to a worse survival in those patients with de novo characteristics and patients with secondary characteristics, both. The important thing to highlight within this context is that we can see that the presence of multi-events, which involves P53, is associated with complex karyotypes in 91% of the cases. Another interesting point, it's true that this included patients with AML, but the presence of variants which affect P53 is associated with complex karyotypes that are typical and includes unbalanced translocations in the short arm of chromosome 17, while those complex karyotypes, which are atypical, might affect other structural alterations or numerical alterations. The frequency of alterations in P53 here is much lower. So if we now face a cytogenetic outcome like the one I'm showing here with an individual, a woman who had a lesion in the short arm of chromosome 5, a trisomy of 6, 8, and 10, a deletion of the long arm of the 11 chromosome and the loss of the chromosome 17, this might suggest that we are facing a multi-hit in this case that affects P53. So therefore, as we were able to summarize, the cytogenetic analysis is the only genetic study with a widely validated role in the establishing of pathogenesis, diagnosis, prognosis, and the selection to treatment. However, the criticism is that around 50-60% have normal karyotypes, 70% present low-risk karyotypes, and from 8 to 15% there are no division cells. As part of the advantages and disadvantages of the cytogenetic analysis itself, we are now facing a massive analysis technique. We take a look at the whole genome, though with a low resolution, which is less than 10 megabases. The other criticism is that it requires a fresh bone marrow sample. We need to use these dividing cells. It has the capacity of detecting mosaics or clonal evolution. It requires highly qualified staff, and there's a delay in the results, more than 48 hours depending on the lab and how urgent this result might be, though there are some claims that there are labs taking more than 30 days. And the other problem is that it requires more than 3 hours of visualizing the microscope, though when we are facing a complex karyotype, this time might be exponentially increased. The cost of this study in Argentina goes from $50 to $150, and the freelance reading is not being well paid, unfortunately, and it is around $50 to $20 per each analyzed case. Now, to decrease this high percentage of negative cases, it is important that the sample comes to the lab in good conditions, meaning that it has to be refrigerated if it will take a long time to arrive, and they have to remain sterile. These are pictures that our technician took at the lab, and we see that this is something that puts at risk not only the viability, but also how sterile they will arrive. It puts the staff in danger, and it affects its biosafety and biosecurity. This is not right. The other important point, and it's equally important, is that cytogenetic studies and the way it reports about karyotypes is consensed, and we have guidelines that will help inform the cytogenetic results. These types of reports might lead to poor interpretation, believing that we are facing a normal karyotype, but if we count the number of losses, we will be taking a look at the normal karyotypes. There are different reports of consensus meetings throughout the years of the International Working Group on MDS, cytogenetic work, which lists these cytogenetic alterations that will help in arriving to a certain risk. The general rule is to have an alteration, any alteration, which is quoted, and more specifically taking as an alteration each numerical change and any simple structural change, and also having a translocation like 2 chromosomes and not bearing in mind the constitutional alterations. However, if we have doubts that they are constitutional or acquired, they should be named as a cytogenetic alteration. When different clones are present, there's only a need to count them once, and if there are tetraploids, we have to take into consideration that the normal karyocytes could be tetraploid, and therefore we need to consider that we might be facing a megakaryocytic hyperplasia. And if we have doubts or second thoughts, we should count it as a single cytogenetic alteration and not a complex karyotype. This consensus had been published before the IPSS revised, and now we know that the presence of the long arm deletion of chromosome 7 has a different prognosis from the loss of 7. Now, according to the consensus guidelines, what we need to try to do is to evaluate as a minimum of 10 metaphases and 20 metaphases if we are facing a normal one. The Myelodysplastic Working Group published some years back this work regarding the presence of a suboptimal number of analyzed metaphases in normal karyotype lower risk MDS, and what they could see is that a not sufficient number of metaphases analyzed will not lead to a difference in the establishing of the overall survival of these patients, both regarding overall survival and leukemia-free survival. However, when we obtain an insufficient number of metaphases, what's advised is to complement the cytogenetic analysis with the use of a FISH panel, as we saw before, since there are many chromosomes which might be involved in the process. So those which are most frequently affected should be analyzed, like the long arm of chromosome 5, D7, SEN8, the TP53 region, deletion of 20, and the loss of Y. Some groups, like the Spanish group, also advises to complement this with array techniques, preferably the SNP array, since they allow, apart from assessing the loss of heterozygosity, the presence of uniparental trisomies. Another frequent question that we receive at the lab is, what is the additional value that complementing a cytogenetic study could have? Well, this work published in 2008, what it said is that the use of fish probes to assess the deletion of the long arm of chromosome 5 will allow or help identify around 6% of additional patients. However, if we take a look in detail, those patients either did not have metaphases or had other alterations involving the long arm of chromosome 5, and this has not been reported as a deletion. However, now, since we have relocated the probes in the deleted region, we can now decrease, and this has already been mentioned, the presence of false negatives within a clinical context associated to a myelodysplastic syndrome with the deletion of the long arm of this chromosome. Another important point is, if the use of fish probes towards the centromere of chromosome 8 increases the alteration detection, and according to the results reported by the Spanish group, it won't increase its detection. Something else that needs to be borne in mind is what happens with the deletion of the long arm of chromosome 7. Unlike the commonly lesioned region, which is one single lesion in chromosome 5, there are 2 or 3 which have been described, 2 or 3 regions in the long arm of chromosome 7. Therefore, the current consensus is to use probes that will map at least 7q22 and 7q36 in a normal area, in a normal cell. What we will observe is 2 reds, 2 light blue, and 2, the light blues will refer to the control, and 2 green marks, which are located in the distal region, which sometimes it's very difficult to analyze in the optical microscope because of its resolution and because of the clear distal region of chromosome 7. So in a monosomy 7, we will have a complete panel. We will have 3 marks only, 1 deletion of the long arm of chromosome 7, the classical 712 deletion, which 7q22 deletion, which might put in evidence the loss of the red and the green, or we can only see the loss of the red mark. And regarding this area, which is difficult to determine with a microscope, if we use this distal mark in the 7q36 region, we will then be able to see the loss of the green mark. These last marks are important to determine the loss of heterozygosity of one of the genes that Dr. Behar has already mentioned during his talk. Beyond all the advantages that we have pinpointed of cytogenetic analysis and FISH techniques, it is also important to determine the access to this fundamental tool, which is mandatory in the establishment of a diagnosis, prognosis, and risk of patients with MDS. Thanks to an initiative of the Argentinian group of myelodysplastic studies, we have designed a survey which evaluates how accessible this will be. The accessibility varies, and not all the regions of our country might have access in the same degree to this study. And also, something that we can observe is that not all the centers can carry out this study in-house, meaning that they cannot do it at their own center, the center where they are studying the patient. So this accessibility to the cytogenetic study is indeed a factor which might be adverse, so that patients can manage to obtain all the supplementary studies that are required for their correct diagnosis. This survey was subsequently extended to other parts of Latin America. In 2017, we collected 425 surveys, including Bolivia, Chile, Ecuador, Paraguay, Peru, and Uruguay. And we can also observe that we don't have the same access to the cytogenetics study. And therefore, in 2018, this study was extended even more, and we were able to obtain information from 684 hematologists that comprises 16 countries of the 20 countries in Latin America, proving that the access is not homogeneous in all of our countries. And we then are able to see how the red color includes none or less than 25% are then increased in countries like Honduras, Bolivia, Paraguay, and Venezuela. This question was incorporated in the last model of this survey, and we see that the FISH study is less available in some countries, and in some of them, the cost of the study has to be paid by the patient himself, something that will also affect its access. It is important to collect information from these surveys that will help us identify how accessible they might be, how affordable they might be to our patients in our region. So I remind you that we have a survey available in the page of the Congress and the Congress's webpage. So if you could complete it, it would be very helpful to all of us. Now, by way of conclusion, we can mention that the cytogenetic study is the only genetic study with an unarguable role, which has been widely validated. It's not that expensive, and we hope that we can collaborate with you to decrease the inequalities in its access, contributing to the formation of human resources. I wanted to invite you to take a look at or listen to our experience in the application of panels in Argentina. We have generated a working group starting on December last year, and throughout the whole country, including all those centers which carry out this study, we could manage to get information of around 80 patients, and it is therefore very important to work in collaboration where the experience of these centers working in isolation will be combined with others. So, well, thank you very much. I wanted to say goodbye. thank you for listening to my talk, and I hope you enjoyed it. Well, thank you very much, Dr. Carolina Belli, for this excellent presentation. Now we will start with a Q&A session for the three speakers. The first question is for Dr. Velloso, a question from one of the doctors here, which says, in patients where there's a clinical suspicion of disease, how do you treat them? Do you resort to the whole genome sequencing directly? Do you study the telomeric shortening? And what would you advise?
Os estudos de telômero. Quando existe um encurtamento telomérico inferior a 5%, a mais, né, bastante importante, esses pacientes são submetidos a seguir a um estudo de um painel de telomeropatias e insuficiências medulares por NGS. No serviço privado, é o oposto. Então, em hospital privado, eu disponibilizo o estudo por NGS e eu tenho mais dificuldade de fazer o estudo do comprimento telomérico. Então, depende de qual estudo que você tem disponível na sua realidade. Deu para entender?
Quanto? Ok.
Não sei qual é o melhor. Eu acho que o melhor é começar pelo telômero, e se for necessário, se o telômero for normal e a hipótese clínica não for tão importante, eu ficaria sem o NGS.
Ok. É lógico. Ok, hay una segunda pregunta.
There's a second question for Dr. Elvira, right? How long does it take to study a donor to rule out germline? How can we look at the mutations? Does it require to talk and present the case with the patient? How long does it take a donor to study the germline? How do we check mutations? Do you need to talk to the patient? What do you recommend?
A linha, a doença e também fazer o estudo de todos os familiares. Quando você não tem essa resposta, quando você não tem a mutação bem definida, o estudo desses pacientes e a orientação é mais difícil, mas ela deve ser orientada independente de você ter o estudo germinativo, a mutação feita. É importante que você tenha o estudo feito pelo hematologista, o geneticista acaba sendo importante, principalmente para as crianças, e a gente tem encaminhado os filhos dos portadores para a pediatria, para ser também estudado.
Que tempo?
How long does it take? How long does it take? There is another question here. This is for Dr. Behar. If a patient has only a severe thrombocytopenia as part of a cardinal germline mutation, is this finding enough to send the patient, refer the patient for transplant? That's a very good question. We must remember that many patients with mutations, for example, ER1, X1, or ENC26, they have a thrombocytopenia much before they had the risk of malignant transformation. So you should not diagnose an MSD just based on thrombocytopenia in these patients. You have to look for other ways of alterations, other forms of myelodysplasia, or more important, the presence of other somatic mutations. Maybe we can say that this patient is closer to a malignant transformation before considering a treatment or transplant. Thank you. Thank you. Do you want to add, anyone wants to add anything? Okay, then let's go. Yes, there is a question for Elvira Velloso. Another question. Patient, 27 years old, with mutations MYH9, congenital plaquetocytopenia, chronic kidney disease in dialysis without transfusion requirement, no marrow bone donor. What would be your suggestion, your behavior here, Dr. Belloso? Did you get me?
Pelo que, bom, pelo menos não tão importante quanto as que a gente conversou sobre hoje. Eu acho que a conduta é
Posso observar, não?
um outro doador, se for necessário. Existem alguns trabalhos com o uso de alguns andrógenos com resultado ruim também. E se a doença não necessita de transfusão e é uma doença de baixo risco para transformação, eu acho que tem que ser seguido.
Seguido, ok. Perfeito. Obrigado.
Perfeito.
We have another question for Dr. Rafael Behar. When you have a donor for transplantation, how do you discriminate the person with the germline mutation or clonal hematopoiesis? How do you discriminate that? Well, yes, at this point we are not sequencing the donors. Yes, we can do it, and we have done it in some cases, in some research cases. And what we have come to realize is that patients that have a germline mutation usually have it with a high frequency. That means that 50% of the sequencing shows that mutation, which means that it's in all the patient's cells. The mutations that are associated with clonal hematopoiesis in general are much less represented in the allelic sequence, and in general as well. So yes, you can distinguish this relatively easily, but we do not do that. We do not look for clonal hematopoiesis in these donors because we have seen that it doesn't make a great difference in terms of the transplantation. But yes, if we know that a patient has a germline mutation, that same mutation, we will look for it in their brother, sister, siblings that might be donors to make sure that they do not have it. Yes, I had a similar question, Dr. Behar. Knowing that form of syndrome, LIFRAM, in which there is a germline mutation of Tp53, which is a form of mutation of that genetic variant, how do we distinguish it from the somatic mutation type? Because that's what you're talking about, the burden, no, of that you find to distinguish the Tp53 germline from the somatic one. Yes, that's much more difficult to do, actually, and that's something that also applies for other mutations. What we are doing is looking at the clinical trial, the clinical situation. If we see that the patient has some other types of cancer or a family history suggesting the inframoney, we take a skin sample And we use it to identify the germline mutations separated from the mutations in blood, so we can be sure if it is somatic or not. But most of the cases, it's somatic. Most of the cases that we have found, yes, it's very difficult. I know, because it's pretty strange. Another question for Dr. Behar. In a practical way, doctor, how can we monitor a patient that is 5Q less with lenalidomide that has a good response? Do we reduce the dose or withdraw it eventually? What is your practical recommendation? Well, we have many options. In my patients, for example, if they are dealing with a drug well, I will continue with it. But some patients start having cytopenias that are not related to the disease, because we have that the frequency of the 5Q has decreased. In those patients, yes, we can reduce with the dose to make it more tolerable. They can continue having it. And for some patients, we give a break. We give a time without treatment. And sometimes we see that the blood counts improve because they were kind of impaired by the drug, and after some time we can go back. So yes, we have a great deal of flexibility with the doses of this medication. Okay, excellent. Thank you. There is another question, Dr. Behar, for you. How can we recognize that a TP53 mutation is sufficiently expressed to decide whether to have a transplant or not? What parameters can we use? For example, what would be the cutoff value of a VET? What are the values here? Well, at this point, we do not really know. We know that if the mutation is present in any BAF over 2%, for example, that is associated with worse prognosis. But if we treat a patient and we see that the frequency of that mutation has decreased, we do not know at what levels you would have a better probability of having a transplantation, for example, without having a recurrence of the disease. At this point, that's what we are studying at this point, actually. What we want to see is that the frequency of the clone that contains a mutation is being reduced with the treatment, and that will give us a better hope that there's going to be success in the transplantation. And sometimes what we do is we consider other forms of treatment, maintenance treatment, that we follow after transplantation in order to try to prevent this relapse. Okay, Dr. Behar, I have another question in this sense as well. Maybe, well, we are looking at how the IPSS is not being enough, the reviewed form also that has incorporated the genetic part some time ago. But it would be interesting maybe to see that in the future. Do you think that we could have a combined form, a prognosis score, type IPSS, but associating these personal aspects when this will happen? Because we've been waiting for a long time, or maybe to have a global tool that can help the pathologists, the clinicians, to make specific decisions in terms of transplantation, for example, management. What do you think about this? That's a very good question, actually. The international group is working in creating a joint program that in which we can incorporate the cytogenetic mutations, the clinical aspects, all of that. And that ends up being more complex than we might think. So it might not be like a table. It might be a website with lots of information, and from there you would be able to identify the risk group. Fortunately, we want to do it in a way in which it is accurate, but also something that it's not that difficult, so that a person that doesn't have access to the website can use it. So that's what we expect. We are working on that to have some sort. We expect to have some form of preview in the ASH meeting in this December, and maybe in the meeting of the European Association of Hematology as well next year. We might have for then a more finalized module. Excellent, doctor. I have another question by Gabby. In low research patients like our patients, could we have a shortened panel of mutations of myelodysplasia for diagnosis and treatment, especially in patients that do not respond to the most accessible therapies in our countries? What do you think? Yes, the gene panel that needs to be sequenced doesn't need to be huge. It doesn't need to have hundreds of genes. In our institution, for example, we have a pretty large panel, but the genes that are the most important ones are really 20 or 30 at most. With a 10 more frequent, you will have a lot anyway. I agree that if you don't have access to a larger panel, a shorter panel can be used without problems. Doctor, I have a question. You do sequencing in a low-risk patient. Do you find any of these mutations when you do that that already indicate the possibility of transformation? TPS 53. Do you see that? Do you do that currently? In those patients, what we do is we follow them up more than what we do in patients that do not have these characteristics. We consider the transplantation if they are candidates, but in general, we do not start a treatment that is aggressive treatment until they have, for example, a transfusion dependence or something like that. So at this point, no, it's not proven that treating them before will necessarily help. But every case, well, we take every case on its own and we do a closer follow-up in those cases. Thank you, thank you. Another question, Dr. Behar. Could you please, based on what you have said, could you indicate which are the mutations that predict hypomethylating responses? I understood that it was TET2, but I don't know if you could maybe elaborate a little bit more. Yes, that's true, TET2. And if you don't have a mutation of ASXL1, that suggests that the patient has better possibilities, better options, better possibilities to respond. But the reality, if we do not have other options apart from the hypomethylating drugs. No, if they do not have this type of mutations, you will treat them anyway. And in this context, so you prefer to give more acetidine, that's acetidine, or is it indifferent for this context? What would you prefer? No, it's the same. It's in the United States, we use acetidine a little bit more, but it depends on the situation. If the patient has many blasts and will go to transplant, the cytarabine might be a little bit more intense, better for them. It depends. Then there is a question for you, doctor, and regarding the new classification that has been proposed. Could you comment on the changes that will be implemented for the classification to incorporate these genetic elements? Or no, the question has already been made, I think. Well, I think that some of the groups that we will find are very similar to the ones that we have already shown for acute leukemia and myeloproliferative problems. The groups with TP53 or complex cytogenetic might be a separate group. There might also be groups with splicing mutations and the chromatin factors. But there will be other groups as well that in reality we have not perceived that we can define based on the genetics. There's a question for Carolina, Dr. Belli. Cytogenetic alteration, would it invalidate the search for other mutations? If so, in which cases? Could you repeat the question, please? Yes, I'll go back to the question. Cytogenetic alteration, would that invalidate the search for other mutations? No, I believe that, well, sorry, Dr. Behar, because he knows more about mutations than me. In my case, I just know for the literature. But the theory is that in some concepts is that once you have established the IPSS reviewed, the high-risk patient, the acquisition or finding more mutations or not, that wouldn't kind of change the higher risk. So the concept would be maybe in patients with lower risk, maybe we could find cytogenetic alterations, maybe we can find molecular alterations, and we can evaluate this context and complement the results. It's additive, yes, it's additional. Yes, it's additional, exactly. And according to most of the prediction systems that are around, there are some works like the recently one published by the European Consortium that shows 8 groups with different classifications of variables, but inside these classifications of molecular variables, they also include some cytogenetic findings. So I believe that none of the techniques will complement the others or replace the others, and maybe in the future we might be able to join them all together. We might integrate the cytogenetic part in our setting where we do not have that too much. We love to listen about all of these, but the reality is that very few patients have access to that in our settings. And Obviously, that doesn't mean that we will not appreciate the information offered by the cytogenetic analysis and the results per se and the classification of the IPSS-R, especially in the high-risk group. Is there another question for Dr. Belli in the case of myelodysplastic syndrome, FISH, for example, a patient with normal karyotypes but doesn't respond to the therapy, would you look any chromosomic alteration through FISH? What it's important, and that's part of what I wanted to say in one of the slides, is that the karyotype shows those cells with a higher proliferative advantage. Therefore, the cytogenetic per se favors the growth of those clones that are more proliferant. That's why we do not find large alterations in terms of chromosome 8, for example, but the chromosome 7, sometimes in that very clear regions in which we do not see cytogenetically, we could get to increase the sensitivity to detect it, but we need to check what are the probes that we are choosing for the detection of these deletions, distal deletions of chromosome 7 of difficult interpretation. Another question is to contextualize. So we are talking about a high-risk patient with a normal karyotype, but if we talk about a patient with a myelodysplastic syndrome with 5q minus and these characteristics, well, in that case, it might help us vis-a-vis the presence of cryptic lesions, or also the presence of cryptic alterations in Tp53, in which maybe the human eye might not be able to observe that, but in general, the P53 alterations can be observed in patients with altered karyotypes. Okay, this is for you, Dr. Belli. This is with regards, what do you think about the study of P53 primo histochemistry in the bone marrow study? Does it have value? Has it been regulated? Do you really know how it works? The immunohistochemistry of P53 is becoming more and more relevant in the literature. The issue is the experience of the person that interprets the result, because it's semi-quantitative and the person needs to gain experience. The pathologist that does the immunohistochemistry needs to gain experience. In the new works, more recent work that has been published in ESCAR and ASH, and it's not only, it's the overexpression of TP53, which might associate to the presence of variants, but also there are some other pathways that might also favor the P53, the aberrant P53 pathway, the overexpression of P53 per se, we have an adverse prognostic factor. Yeah, it's not enough to evaluate all the forms of hit or alterations because it's pretty complex, P53. Yes, indeed. Because if you have deletions, you have absence of P53. Yes, of course. That's why the concept of a multi-hit, one hit or one cytogenetic hit, allelic or multi-allelic. Yes, if you don't have P53, you won't have overexpression of P53 because it's not there. Yes, okay, thank you. Well, we are running out of time. We have time for a couple more questions because we are just in time. But there is one last question for Dr. Velloso. Mutations in some 9 and some 9L can they be as important as a tattoo to explain monosomies in pediatric patients?
Existem duas mutações na mielodisplasia da criança que são muito prevalentes com a monossomia do 2 e a segunda é Sandiel e Sandiel 9. Eu queria só retificar uma coisa que eu falei antes, que eu acho que eu não entendi direito a pergunta, que é a respeito de quanto tempo a gente leva para achar se o doador de medula familiar é portador ou não da mutação. Me desculpe se eu entendi errado, mas na vigência de uma mutação conhecida no paciente, a gente desenvolve os primers, solicita os primers e faz o sequenciamento apenas da mutação germinativa em todos os possíveis doadores. E esse é um prazo que não excede, mesmo no nosso meio, 3 semanas. Então, eu talvez tenha me expressado errado na pergunta que o Juan me fez. Peço desculpas, tá? Agora, se eu não tenho o estudo, né, se eu não sei qual é a mutação, isso transforma a coisa numa... Isso é muito mais complicado. Então, me desculpa, mas por volta de 3 semanas, desenvolver, né, pedir o primer para fazer o sangue e fazer o sequenciamento de primeira geração.
Puedo agregar.
Can I add something about some DL9? Please allow me. Well, the issue of those variants are very interesting because they might tend to revert. So the concept of reversion through mechanisms, so parental trisomy acquired that reverts, and maybe the minosomy of 7 disappears, that's related to GATA2. So those patients, you need to follow them closer because they might end up reverting their cytopenic status and might not require bone marrow transplant, but you have to follow them up very closely because the specific behavior of those variants is very specific, very particular in each case. And there might end up not requiring the transplantation. Excellent, excellent presentation by everybody. We have run out of time. We have to close this session. Thank you very much, Dr. Behar, Dr. Belli. Thank you very much, Dr. Elvira. We have had excellent presentations. It's been excellent for everybody. Thank you very much to everybody and to all the audience for your presence here. Well, there were some few questions that we could not answer, but we have run out of time. And thank you very much to everybody. Thank you.